in broad practice in the US, and I think even more in the rest of the world, the reality is that a lot of patients don't get concurrent chemo and radiation, and then there's a fallout, and a lot of patients don't get immunotherapy. Millie, I'm really interested, particularly because you're in a VA system that is not a highly selected population of younger, extremely fit patients. Is it common for you to have patients who you think are not strong candidates for concurrent? And I'll say that I worked in a community-based setting that's a pretty broad range of patients, and I moved from giving concurrent cisplatin and etoposide chemo with radiation, which is pretty rigorous,
yes,
to a lot more weekly carbo and paclitaxel. There are data to support that, and that is much more tolerable overall. I think it leads me with the question of whether any ambulatory patient who can walk in on their own power is not a candidate for that. But I'm interested in your thoughts, because you probably see some patients who are not doing handstands and Olympic candidates here.
Right. Yeah. I mean, I think, as you mentioned, cisplatin etoposide is a very difficult regimen. It's a regimen that I'm not frequently giving to patients at the VA, usually due to just baseline hearing loss, renal insufficiency, things like that. But the weekly carbotaxol regimen is very well tolerated. I've treated patients in their upper 80s, even low 90s with the, weekly concurrent carbotaxol radiation, and they've done okay. And one of the great things is that you can try it, and then you can, drop it if they don't tolerate it. But it is a pretty good, well-tolerated regimen. That I think the RTOG 0617 trial employed that regimen, and the, median survival time was, quite good in that trial, and I think it lended support to that regimen. A lot of us sort of felt that maybe it was inferior to the cis-etoposide regimen, but I feel confident about being able to administer that with a definitive cure intent. And so most of my patients are able to get the concurrent chemoradiation with the weekly carbotaxol regimen. There are, I just in the past few months, I have seen patients who are more kind of ECOG performance status 2 bordering on 3, where it makes me nervous to give them chemotherapy. They may have had, a recent cardiac event, something like that. In that case, I will talk to them about the options. Generally, it's good to know up front whether you're going to give a concurrent chemotherapy regimen, because the radiation oncologist may want to give a more hypofractionated course of radiation.
Which is a short course of fewer treatments.
Right. A little bit higher dose. We generally don't give concurrent chemotherapy during the shorter. So instead of 6 weeks of radiation, they may shorten it to 2 or 3 weeks. Easier for the patient. We won't give chemotherapy during that. We think cure rates are lower with that approach, but I think, for these patients, you have to weigh risk benefits, and most patients in that situation sort of understand that the chemotherapy may do them more harm than good.
And I think it is worth noting that this is a situation where there are competing risks of it's the cancer, but many of these people have bad emphysema, COPD, other medical problems that may limit their probability of surviving several years. Mm-hmm. And we do want to make sure the treatment isn't worse than the disease. I think that one of the challenges we've had, and this is just my gleaning the data that are not very strong out there, is that part of the mixed results we've had with intensifying with additional chemo is that there is such a wide range of the extent of disease called stage 3 and the health of the patients who have stage 3, that some we may be helping and some we may be harming by turning up the dial into a dangerous range. And so I think at some point you do need to individualize, especially for the people who are on the outer limits. Matt, what's your approach? I mean, is this something that is vanishingly uncommon at UCSF? Patients who are not candidates for concurrent, or and most of these patients are going to be treatable with at least weekly carbopaclitaxel, or what is your thought process for, say, an 87-year-old who's PS2?
And PS2
performance status being fragile, but
walking in the
treatable.
clinic.
Yeah.
And also, by the way, that 80-some-year-old has some ideas about the therapy they want also.
Exactly.
And when you lay out what chemoradiation looks like and what the chance of cure is on the other end of that, it's a shared decision making. I'm not being glib about that. I think their patients have very strong feelings about that. But we also see those patients who are just not quite fit enough to do the chemoradiation and not have a lot of toxicity. And so it's just a very personalized decision about whether maybe sequential doing a chemo and then radiation or vice versa. The other kind of variable in the mix is there are patients, again, stage 3 is such a wide range of patients. There are some patients where our surgeons say, well, I wouldn't operate on them today, but if you did this and shrunk them, maybe I could. So sometimes some of the discussion is actually giving a little bit of chemo and seeing what happens to see if we then decide to do surgery or do chemo and radiation or what have you. So kind of all these, stage 3 is the one tumor that we actually talk about almost all of our patients in a tumor board setting, which we're thankful to have in an academic setting.
Let's take the scenario of a patient who had an initial discussion and was on the bubble for surgery. I really wonder about how to best treat these patients because many patients, many docs feel get it out, that it's always desirable. And we have data in stage 3 borderline resectable to say that it's about equal if you can get people through it to do the surgical approach with a little bit of chemo and radiation beforehand or chemo alone versus doing more intensive chemo and radiation and omitting the surgery. And they're about the same, and it may depend on how extensive the surgery needs to be. But it's not that clear that just because you can do surgery, you should do surgery.
Totally agreed. And especially in this kind of immunotherapy era where that's changed the number. So if you're already on the fence about it, but if I don't take a patient to surgery, do the, as by all accounts, equivalent effectiveness of chemo and radiation, but I've got this kind of, again, brass ring on the other end that has a shot of improving how long it lasts, or maybe, just maybe curing, that I don't have as an option as an FDA-labeled treatment in a surgical situation. Even our surgeons are trying to say, you know what, take them to chemo radiation and give them some immunotherapy, and
I suspect
we'll
it
talk to you
depends
later.
on the surgeon.
Probably true too. Yeah.
But as you said, as we agreed, before immunotherapy was on the scene, it was a very marginal, debatable story, and then immunotherapy raises the utility of a non-surgical approach, which to me would lead me to think that we should tip the scale more toward a non-surgical approach. And yet there is still this gravitational pull towards surgery. So my real question is, do you think that this has led or should lead to a move away from surgery because immunotherapy tips the scale clearly in favor of a non-surgical approach for stage 3?
I mean, I think we really don't know. I think for someone who really wants to have surgery, I mean, there's just certain patients who are convinced that that's what they want, and if there's any possibility of them having it, I wouldn't tell them not to do it. And again, surgery is kind of a one and done deal, whereas the immunotherapy, it's a year of therapy, right? And there are patients who just don't want to sign up for that.
And I think that the year of an ongoing treatment is a big thing that we shouldn't underestimate. It's
every 2 weeks.
Every 2 weeks for a year. My patients love seeing me, believe it or not. But I think it's a very fair point that you've now made treatment go from 2 months or less to a year and 2 months, and that's a big change. And you've turned it into a chronic management. So, fair point. One variant on that is you have a patient who could go to surgery after chemo radiation or could do chemo and radiation followed by immunotherapy. I have had surgeons or other people who say, well, how about I do the surgery and then the immunotherapy? Now, we don't have data for this. I'll say that one interesting thing that we need to learn more about is whether extensive surgery and removing lymph nodes decreases the efficacy of immunotherapy. And there's a bit of evidence, though not enough to say much, that removing a lot of lymph nodes could be harmful to the efficacy of subsequent immunotherapy. So is this something that if a patient were to ask you about, can I just do surgery and then do the immunotherapy afterwards, or the surgeon suggests, oh, you can get the benefit of both. What's your view about that?
I'm going to hew to the data that we have. And for now, really, I think the strength of this trial we're talking about, Pacific, really was the utility of giving immunotherapy fairly close in time after a chemoradiation exposure. And giving immunotherapy after surgery is a whole different question. Again, whether the nodes are there, what other things we've done to kind of poke the skunk. Like, there are adjuvant trials, we say, where you give immunotherapy after definitive surgery that we're waiting on results for. So we'll have an answer in a year or two, we hope. But I think for now, I wouldn't do it off-label.
Okay.
Agreed. I wouldn't do it outside of a clinical trial.
We'll need to get that clinical trial someday.